Prof. Thank
Yes.
you. I'm very fortunate of has been breastfeeding by you. Always the best. Prof, we have few questions here. We have on the university side, the Professor Eduardo as well.
Yes.
Please, Eduardo, we can coordinate the questions from your side, but I have here one question in the YouTube regarding iatrogenic preterm birth. The question is, in the prediction of iatrogenic preterm birth, in the predictions of preeclampsia, if I goes only with uterine artery, Doppler, plus clinical factors, including blood pressure, what is the detection rate? Because here in Brazil, we don't have easily PLGF. It's enough.
It's a very good question. So here is the summary of the triple test, the prediction by using all three, uterine artery Doppler, blood pressure, and PLGF. And if I look at 32 weeks, we detect about 90% of the cases. If we don't use PLGF, then it's not bad. The detection rate is about 80%. So we can use that. But there's something else, Eduardo. When we do screening, we have two things. We have the screen positive rate and the detection rate. And if you use the double test rather than the triple test, you can accept a screen positive rate of 15% to also achieve a 90%. So if we accept a screen positive rate of 15% rather than 10%, the combination of uterine artery Doppler and blood pressure will also achieve a 90% detection of very early preterm birth.
So, Prof, actually, it's the same model of nucleotranslucence. If you the biochemistry, you are going to increase about 10%. But here you can work with the screen positive rate, and then you can have the same 90% with a few patients more.
Excellent. Exactly. Because it doesn't matter, Eduardo, because in the case of Down syndrome, for example, the higher the screen positive rate, the higher the amniocentesis of the CVS, and therefore the higher the risk that you will lose babies. But here, what does it matter if the screen positive rate is 15% rather than 10%? You will give aspirin to a few more people than without. So it's not such a big deal. Yeah.
Excellent. We have another question here. If the patient is at high risk in the first trimester for preeclampsia, I will start aspirin. Here in Brazil, we don't have 150, so we can use 81 milligrams twice at night, and then we are going to have 162 milligrams. Do you think it's enough, or we could use only 100 milligrams? What is the best? 100
you can use. We have done a meta-analysis after the aspirin trial, and you have found that if you give from 100 onwards, that is sufficient, provided you start before 16 weeks. Yeah.
Perfect.
100.
Another thing, Prof, another question. If the patient is high risk at the first trimester, I start aspirin, and how I should follow this patient up?
Yeah, I think that the women would have a routine ultrasound examination at 20 weeks. And then if you look at the uterine artery Doppler at that stage, and if the pulsatility index is high, I would do another scan at around 28 weeks, and then 32 and 36 weeks.
Perfect, excellent. So, Prof, I'm going to ask to Eduardo in the university site if they have some questions there, because I have a few questions more here from the YouTube, but maybe Eduardo can help us in the university site. Do you have any questions there, Eduardo?
Professor, I don't see Eduardo here, but I'm talking to the students in the university, and they are asking about measuring the cervix in the first trimester. What's the meaning of that? Should we do or should we not do?
Yeah, thank you very much. The students in Brazil are very clever. So in the second trimester, this is how you measure the cervical length. And there is a very clear definition, and there is clear distribution of the cervical length that gives you a high risk if the cervix is less than 25 millimeters. What is the situation in the first trimester? In the first trimester, there is a very high thickness above the cervix, and the margins are not so easy to define. And when we did studies, we found that a short cervix was only 1 or 2 millimeters shorter in the group that had premature delivery, and therefore, to me, that is not good enough to recommend as a method of screening.
You said that there is a question, please.
Yes, someone is asking about aspirin in twin pregnancies, just for the fact of being twins. What yes. Do you recommend?
Yes. Unfortunately, because of COVID, we were very much delayed, but we have been planning things now for 3 years to do a trial in twin pregnancies. We call it ASPRE-T for twins, and we have now started. And this is a multi-center study involving many different countries, and it's also being done in Brasilia. And we do not know if it is useful or not. So we are randomizing women with twin pregnancies from 12 weeks to receive 150 milligrams of aspirin against placebo. The incidence of preterm preeclampsia in twin pregnancies is 9 times higher than in singleton pregnancies. So I cannot answer your question now, but maybe in 3 years, I will give you an answer from the results of the trial.
Prof, I think we have just more 3 questions, and then we can finish, because I know that it's late for you. So the first question is, here in Brazil, people is still, sorry. So shall we indicate or not pessary in short cervix?
I mean, Eduardo, the results are very highly contradictory, isn't it? This is the results from Goya, a group of friends of mine, Elena Carrera's group in Barcelona, where they put a pessary against the control group. What was extraordinary in this study of 380 women with a short cervix at 20 weeks was that in the control group, the incidence of preterm birth before 34 weeks was 27%. That's extremely high, very, very high. And people say that the big benefit that was shown here maybe is because for one reason or another, the placebo group did so badly. In our trial, the incidence in the placebo group was 11%, and in the pessary it was 12%. And what is particularly interesting is that half of our patients were from Spain, because we were recruiting several Spanish centers. So I cannot explain this big controversy in results. And then we had a series of other studies, and this is what I summarize here. The Romero group published 2 years ago this meta-analysis, and you can see the results of Goya, how they are extremely good, but without the studies, without the other groups, there was no such benefit. So overall, there is no good evidence that the pessary is working. I know Romero published 2 years ago. I know that some people in Brazil are supportive of the pessary. Yeah.
The last questions, actually, there is just 2 questions more, is what I used to say here in Brazil, when they ask me about pessary, I used to say that in my point of view, the pessary must be used only university for student proposal. So it's not time to do in the medical practice out of studies. I don't know if you agree.
Yeah, I agree with you. Yeah.
So, and what about sludge? So, a symptomatic patient, long cervix and sludge. Shall I give antibiotics or just wait for a couple of weeks and to understand that this sludge is not sludge?
Yes. So this is the work, especially that was promoted by Roberto Romero. It is still difficult to define what is this sludge. In some women that have complained of bleeding, when you do an ultrasound scan, you see this echogenicity within the amniotic fluid and floating bits of white bits within the amniotic fluid. And in some cases, these echogenic bits settle into a block on the lower end of the uterus. Is that what the sludge is? So is the sludge a marker of intraamniotic bleeding, or is it really a marker of infection? But if there's a marker of intraamniotic infection, is it possible that you have no symptoms at all, and somehow these women will develop chorioamnionitis and they will go into premature labor? I find that difficult to believe. You see, a sludge is not properly defined, and then you start treating with antibiotics. Which antibiotics? In how many? In what dose? Intravenous antibiotics, high doses, to treat a theoretical intraamniotic infection? I suppose somebody could argue that if you see the sludge and you're very, very worried of premature birth, you might as well do an amniocentesis and see whether there is really an infection or not.
Okay, good. So for the last question, and then I will pass the final words for my namesake, Eduardo, in the university. I would like to discuss just a bit about the events study. What I learned from the events that I should perform cervical assessment for every single twins in order to avoid unnecessary progesterone, and maybe to give progesterone for those with a very short cervix, less than 30 at the first trimester, or less than 25 at the second trimester. My question, this is my question. Is it time to treat twins with short cervix, less than 30 in the first trimester, or less than 25 in the second trimester by endovaginal scan by progesterone?
So the results, these are the results from the events study. If anything, if you look here on the odds ratio, in the women that received progesterone, there was a tendency for an increased risk of premature birth. I don't know what does that mean. It was in a secondary analysis where we found this finding in a very small group of women. It was 13% of the population that had a cervix of less than 30 millimeters. I have already answered the question, Eduardo, that the definition of a short cervix in the first trimester is not very clear, and the measurement of the cervix in the first trimester is not so reliable. So I think to start getting very excited about routine measurement of cervical length in the first trimester and treating with progesterone 600 milligrams every day for people with a cervix of less than 30, I think it is too premature. It is not conclusive in my mind, this secondary analysis data. What about the second trimester? Yeah, although there is no good evidence that that is beneficial, I do it. So if I see a woman that at the routine 20-week scan is carrying twins and the cervix is less than 25 millimeters, I cannot just ignore that measurement. I would definitely treat this woman with progesterone, most probably 400 milligrams, 200 in the morning, 200 in the evening, see her again after 1 or 2 weeks. And if the cervix is continuing to get short, again, without very clear evidence, I would put a cervical cerclage. You need to do something. You cannot observe a woman with twins at 20 weeks with a shortening of the cervix. You know that she's heading for very premature birth and she's going to lose the babies, and just say, we will do nothing because there is no good scientific evidence that anything is useful. For the individual woman, I would definitely try everything, even if I don't have good evidence that it would work.
Thank you, Prof. I think I'm going to finalize from my side, because now it's almost 8 hours in Brazil, and it's almost 11 o'clock there. So thank you a lot. You are always great, and I hope very soon to be there with you. Thank you.
Thank you very much, Eduardo. And thank you, Daniela. And nice to speak to the students. Thank you very much.